Well, thanks very much for inviting me to this conference. It's a profoundly interesting set of presentations, and I wish I was here from the beginning. I came in today, and I was able to scope out some of the posters. I wanted to thank Dr. Catherine DeVries and Dr. Ray Price for inviting me and for organizing it. I read the biographies of everyone here, and I didn't realize that I'd read mine too, until I went back and said, you know, they must have just taken this off the web, and I didn't fill in my bio sketch that much. So part, I think, of the reason to be invited here is a deep experience with cost accounting as applied to illness. Another is some brief stints with international organizations in terms of the application of those methodologies. I would say, in listening to Dr. Meara this morning, one of the messages I would have is a little bit more of a cautionary note with respect to the application of cost accounting and economic accounting to disability and to health. And while there are more integrals in his talk, I would say that hopefully you'll find that some of my points are integral. So why do I call this From Kaleidoscope to Prism? I'm trying to figure that out myself. I think it's partly the way that we think about organizing the world. There's several points of light which are mesmerizing, and this is also going back to sort of a political framework in terms of recent, well, not so recent now, elections with regard to the degree to which we can make contributions in our society. And the Global Surgery Initiative that I've learned about is a profoundly interesting and important initiative. And I think that in terms of organizing it in a way that brings new light to it is important. And maybe economics and economic analysis has something to bring to bear with respect to it, but it's something as well that I think is a cautionary tale. So with that little introduction, From Kaleidoscope to Prism, casting light on economic considerations related to extreme affordability, which is a cool title. The global burden of disease. The absence of timely and surgical interventions are a significant contributor to global burden of disease. Surgical training interventions and enhanced infrastructure can help this component. Can economic evaluation contribute to integration of effective and efficient interventions? Let's take a look at a characterization of the GBD through the lens of dollies. And it's nice to have seen a couple of the posters here present in this framework. Apparently the audience and the participants are very well versed in some of this, so this is going to be repetitive to some extent. But I think it's valuable to revisit it in perhaps a new lens. And I was particularly taken by the ICER poster over here that basically comes to the conclusion that we ought to revisit the nature of the effects and benefits of surgical intervention at a district hospital level rather than on a disease level. And that is sort of similar to some of the points that I would make. So here's, this sort of looks kaleidoscopy. This is from the Global Burden of Disease, published just a couple months ago in Lancet. And this is cancer. And it's dollies per 100,000 people. On the left are the higher income countries. If you look at it on the right are the sub-Saharan African countries. And you can see the distribution of cancer. This is not surprising to see in terms of the conversion of dollies, the neglected tropical disease, disability adjusted life year rates, and by cause and region in 2010. So you have there several of the SIACs that I can't pronounce, and you also have hookworm and rabies and so on. This is even more kaleidoscopy. This is sort of a summary of the entire global, by the way, this enterprise on the global burden of disease, I don't know the degree to which you know it, but Murray and Lopez basically kicked off this enterprise over 2 decades ago, and it's alive and well with major support now through the Gates Foundation and others. So this conversion into DALYs of basically all diseases, the flattening of disease, if you will, into one metric is going forward at a pace. And what this shows on the left-hand side is basically the top 85 or 90 so diseases, with the top being sort of the top 10, and then breaking down the rest of the world as to how they would be configured. There are 291 in total, so the blue ones that would be even further down make their way up when you start going into the various regions. And on the right-hand side, you can see the distribution of disease in some ways are substantially different from from some of the very high-income countries, as you would understand. Although the major point of the 2010 iteration of the GBD assessment is that non-communicable diseases are rising and becoming a very important part of the developing world's configuration of the DALYs, or of the global burden. Now, I've put big arrows on the left of a few entries that I thought might be interesting with respect to the group on surgery, preterm birth, congenital anomalies. There's one on injury, another on, I don't know, I can't even read it from here. So maternal disorders, etc. Certainly there are components there where there are big surgical components. This is just another sort of, this is more prismatic, I guess, in terms of a representation, A and B being a female and male, and then you have by age, and it's global, the global burden of disease, again, by category. And it's, what's nice about this article, it's online, with the latest iteration just a couple weeks ago, and you can go in and you can play with the pictures here to home down to various regions and diseases and so on and so forth. All of these, each one that I've shown, is actually a utility that you can isolate certain facets if you'd like to on your own. So we've been talking a lot about the DALY, and as I indicated and as mentioned before by Dr. Mira, this is an important configuration or measurement of disease. And just to go over it in a more simplistic fashion, the DALY is a sum of YLL, years life lost, and years lived with disability. It's as simple as that, until it gets a little bit more complex. So the YLL is a multiplication of the number of deaths at age X by standard life expectancy at age X. And YLD is the prevalence of disease or injury sequelae multiplied by disability weight associated with each sequelae. That's kind of tough to think about. And oftentimes that's the part that's skipped over in terms of our understanding of the calculus behind the DALY. I'll come back to that, but I mean, the weights here come from surveys of the general population rated to attributes of disability, and then we reconcatenate it. So the methods for establishing disability weights are not that different from what you might be more familiar with, the qualities, and except this is, of course, inverse to that on the 0 to 1 scale, where 1 is bad and 0 is good. 0 is the absence of a DALY. Sequelae are configured to avoid double counting, provide exclusive attribution with single conditions or set of 291 conditions. Note when we think about various diseases that we do surgery on, for example, cleft lip, that there are often many, many comorbidities there associated with it. And when you establish these sequelae, what you're trying to do is to home in on the cleft lip itself and avoid all of the other types of comorbidities, the heart and other types of conditions that might be coexistent or higher on sort of that causal chain. DALY is increasingly recognized by the World Bank, WHO, among other international organizations. So we're getting a little sense of the prism of economic evaluations. Interventions such as surgeries increase longevity, reduce disability, and thereby reduce DOLIs. They're an estimated 11% of DOLIs, of total DOLIs, are associated with surgical conditions, which is an interesting fact in and of itself. And they have associated costs to reduce those DOLIs. These interventions with lower cost per DOLIs are more cost effective than those with higher. We haven't really differentiated ourselves really with what's gone before. And then we create these incremental cost effectiveness ratios, these ICERs, that could be generated, quite frankly, for every single condition. And it's a project that the group might actually think about with some value. This hasn't been done, as far as I know. So a very recent study, one that actually didn't make it to the poster because it's so recent, is a study of a Cameroonian district hospital as an illustration. This is El Bawi et al. It's a very well done study, by the way. The average cost per DOLI for all operations, $27.13, generally a favorable ratio by almost any metric. And still the utilization was found to be inhibited by costs at the hospital level and out-of-pocket payment at the patient levels, certainly demographic factors, and patient perceptions. Now, one of the things that this slide attempts to show, it's too small probably for many of you to see, is the way that the results were presented in this very good piece. They were done by individual diseases, right? And then you get the average cost per case, you get the average DOLIs, and then you come up with some sort of measure of the CEA based on the average rather than the incremental cost per DOLI. And I would say this is kaleidoscopic, quite frankly, in the way that it's presented, because it's a summary of basically things that take for granted a certain level of infrastructure, a certain type of procedure, and then we're basically plopping this down, these surgeries down. Not that it's not interesting, not that it can't be helpful, but it's still kaleidoscopic. Total cost entails not just direct outlays, but time. This is recognized on several of the posters. Travel time can be particularly onerous, of course, in the developing countries, as many of you know. Broken roads, broken economies. All of these things add to the cost, or detract to the costs associated ultimately with the surgeries. Survey of 14 hospitals serving close to 1/4 of Ugandan population. Mean population served per hospital over 500,000. Patients had to travel a mean distance of 33 kilometers to reach the hospital, one surgeon per approximately 1 million population. You know this. This is pretty standard stuff with the kind of material that you're looking at. So despite the favorable ratios based on World Bank or WHO standards, surgery still often yields ratio not as favorable as broad public health or non-surgical care interventions. The example of incremental cost effectiveness of maternity care interventions in an expansion path. We're trying to organize now, this is basically coming from the WHO perspective, where they're trying to organize basically certain types of paths for care for particular kinds of diseases or sets of diseases. And this piece by Adam et al., I think, reflects well this kind of organization of a set of economic analyses. And here's another website for you that you can play with that has all of the kinds of costs for various conditions on it. And I've just homed in a little bit on one area of Africa and on a paper related to an expansion path for maternity care. You can also play with this on the web. Again, might be difficult to read, but basically what this is, going from A1 to A12, are increasingly more resource-intensive interventions for maternity and neonatal care. And that is what you see as an organized set of ICERs, incremental cost effectiveness ratios, from the least to the most, and from the sort of the most elemental interventions to the most complex. Several of the points, by the way, would include certain surgical interventions. It's not just toward the end. So some of the foibles that I would just point out here, there's tons of them, with the estimates of qualities and cost, for example. We got a pretty good piece of it in the last lecture, by the way, on opioids. People think they know what cost is. You don't. So the survey methods for eliciting weights based on a utilitarian calculus that may not reflect the true individual, let alone societal values, is a very critical philosophical underpinning to this whole so-called science. It's not something that we should abandon, but we should be very much aware of. There's a famous article on the Oregon healthcare plan written by an MD by the name of Haydorn that noted that tooth capping was a higher priority in the original plan than was surgery for ectopic pregnancy, and splints for TMJ were ranked higher in terms of importance than appendectomy in Oregon. And why? Because it was based strictly on cost-effectiveness ratios on qualities. It can get you there, believe me, it can. So important disparities are often glossed over. These are averages. All of these measures are averages, both on the cost and on the disability side. Economies of scale can absolutely bias these estimates if they're not present or if they are present. There are incredible dynamics involved with respect to what is going to be the trajectory over time. And when infrastructure changes, so does the disease. Disease pattern is absolutely endogenous in many ways. Economic evaluation is a tool that can be easily misused due to inappropriate assumptions, over-reliance, and misapplication. But it can help as one part of the guide that public health officials and other important stakeholders use to evaluate surgical priorities and interventions. Moving from Prism to Prism. The method can imprison us. Moving from Prism to Light requires concerted planning and development that appropriately recognizes both the strengths and limitations of cost-effectiveness analysis. Thank you very much.